Good morning, everyone. My today's topic is new modalities for acute DVT management, Pharmaco-Mechanical Lysis. DVT is a very important subset in today's medical context. It's very important to treat this disease very early, else we can get a complication in the form of a deadly disease called pulmonary embolism. And the late complications of DVT are venous hypertension. Slide is not moving. So late complications are venous hypertensions, which can lead to secondary varicosities. If we treat it early, the symptoms are resolved very dramatically. And some people use temporary cable filter along with the lytic and pharmacomechanical therapy. So lysis can be pharmacological or it can be mechanical, or both can be combined together. So there's an excellent system available in the country nowadays, which is called AngioJet. It's a thrombectomy system designed to effectively remove the thrombus, aspirate it, pulverize it, and decrease the complication. What are the benefits of this system? There's a quick restoration of flow, which improves the vessel patency, target lesion visualization. There is very less distal embolization, and you can treat the thrombus of various ages with this machine. This is a console on the left-hand side, and this is a catheter, which is called Zelante. It's a 8 to 9 French compatible catheter, which works on the principle of Bernoulli. As the velocity increases, the pressure decreases, and you can pulverize the clot and aspirate the clot. So this machine has a propeller which rotates inside with very high speed, and saline jets are coming out of the nozzle, and then which breaks the clot into small particles. And then there is an aspiration port just behind the saline port, which aspirates the clot. The catheter is selected on the basis of location of the clot, whether it is in the femoral, whether it is in the iliac or in the IVC or in the pulmonary artery. And then volume of the thrombus decides whether we can give a pulse therapy or a lystic therapy. In the power pulse therapy, physicians infuse a fluid inside the thrombosed vessel, which is inside the thrombus. You infuse a tissue plasminogen activator or whatever lytic agent is available with you. Normally we use Actilyse. We can use tenecteplase and urokinase if there is a cost constraint. And in the thrombectomy part, high velocity saline jets are creating a low pressure zone at the catheter tip, which is as per the Bernoulli's principle, which allows the aspiration breakup and removal of the clot. So these are the different catheters available: Zelante, Solvent, and Solvent Omni. But in the DVT, we use Zelante catheter. This is a patient who had right leg DVT. So patient is made to lie in the prone position. So this is the right leg. And we take popliteal venous access under the ultrasound guidance, and then we do an angiogram which shows the superficial femoral vein is full of clot, and the iliac vein is again external iliac vein, common iliac vein is totally occluded and full of clots, and these are the collaterals from where the blood is going up to the heart. This is how the patient is made to lie in the cath lab. Patient is in a prone position, and in the left popliteal fossa we have done a puncture. This is an 8 French sheath through which the 035 wire goes inside, and then you do angiograms. Angiogram shows the presence of clot in the superficial femoral vein. You can see above the popliteal vein there is no flow. It is totally occluded. And then you aspirate the clots. These are the clots which are aspirated. And then this is an infusion catheter sometimes you use, which has multiple side ports to infuse the drug. This is how the popliteal venous access looks. And when you leave the catheter in place, you just make it a coil and then tie the catheter. So this was the you can see external iliac vein, common iliac vein, the wire is going up into the IVC. IVC is also occluded, and there are big collaterals from the lumbar vessels. And this is after few passes. You can see now the common iliac vein and the external iliac vein is totally visualized, and there is a good flow to the inferior vena cava. And then the next day, after the complete course of lytic therapy, the patient was made to lie in the supine position. So what we were seeing on the left side now comes on the right side, because now the patient is supine. So this is common femoral vein, this is external iliac vein, and this is the common iliac vein. Absolute clearance of the clot, and you can see the venous valves which are patent. So there is a prompt symptom resolution. very less chances of late venous valve failure or incompetency. So this is a catheter which is 8 French compatible. You can give contrast injection through the side port of this catheter, and you can exchange it over a multiple wire. So this is a over the wire system. Again, this is a 53-year-old male who had massive DVT in the left upper limb after some strenuous exercise, which is called muscle bridge related subclavian venous injury. And you can see the left axillary vein, subclavian vein was totally occluded, and multiple collaterals can be seen going through the axillary area. And then this angiojet was deployed from the brachial venous access, and lytic therapy was given, followed by subclavian angioplasty because there was some stenosis in through the proximal part of subclavian. This is a angiojet which can be rotated 360 degree, and in the different areas aspirations were carried out. And once the whole clot was removed, we did a balloon angioplasty into the proximal part of subclavian vein. And then in the last part, we can see the good flow was established from the innominate into the subclavian vein. And this patient had received a stent in the common iliac to right external iliac vein for May-Thurner syndrome, which is a syndrome in which the artery compresses the vein. And this patient had a stent failure because the stent was totally occluded. Now you can see when you inject from the common femoral vein, we did a angiojet. This is a 2 ports of angiojet. From this one radio-opaque marker, you can rotate and then you do balloon, multiple aspiration cycles, and then lytic therapy. And once everything was done, the flow was established. So because this is a low flow circulation, the failure rates are higher, but there is no other option. So this patient received stent, and then after the stent failure, this patient received a angiojet therapy, and after the balloon angioplasty, good flow was established in the iliac vein. So this is the last shoot, which shows a good brisk flow, antegrade. So similarly, pharmaco-mechanical thrombolysis can be performed for the pulmonary embolism. Blood flow is established immediately. There is a thrombus burden which is reduced, and hemodynamics are improved in the form of normalization of pulmonary artery pressure and increased and improved oxygen saturation level. So this is a left pulmonary artery in which we can see there are multiple clots. Angiojet was deployed, thrombectomy was performed, and then the last cine we can see good resolution of the clot into the left pulmonary artery. Again, another patient with left pulmonary artery thrombus. Final pulmonary angiography reveals good recanalization and hemodynamics improved. So small clots can embolize distally, but they can be managed with the help of lytic therapy. There is a very small risk of cardiac arrhythmias because there is a fluid imbalance in the patient. We have to use systemic heparin along with, because we are using intravascular hardwares. Because this is acting on a pressure-based system, so there is a transient hemolysis because of the breakdown of RBCs, and the patient can have black urine or hemoglobinuria, which should be monitored with proper hydration, and if required, blood transfusion should be given. Thank you so much.
Thank you very much. And questions?
Thank you, Tarun bhai, for an excellent presentation. What percentage of these cases would you be putting an IVC filter prophylactically, or is it rarely indicated?
If there is a free-floating clot in the common iliac vein or the inferior vena cava infrarenal part below the renal veins and up to the renal veins also, then we should put a filter either in the suprarenal part or the infrarenal part.
For pure iliofemoral DVT, you would not be using a filter routinely?
There is mixed review across the world, sir. Some people they use in every case, but some people they do not use, because then removal of filter is very, very important. Like you can't let the patient go with a filter. So if you have a good follow-up, you should put a filter and then call the patient back for removal of filter also.
Second thing is, if you find a May-Thurner syndrome as the cause of DVT on the left side, would you be stenting at the time of pharmaco-mechanical thrombolysis, or you would like to wait for a few weeks?
Generally, sir, we allow the venous compliance to get better after 2 to 3 weeks and then call the patient back again and then do a repeat Doppler or CT venography. And if availability of peripheral IVUS catheter is there, we do a peripheral IVUS catheter to look for any web inside the vein or any area of constriction, and then we do a stenting. And these venous stents are dedicated stents, like we should not use commonly available large diameter stents. Only dedicated self-expanding venous stent should be used, like Vinovo or sinus stents.
How much is the failure rate after you do this intervention? Venous.
15 to 20% failure rates, because it is a low flow circulation. So anticoagulation has to be very aggressive. Usually we give rivaroxaban to all these patients, 20 milligram once a day. And if there is a high prothrombotic burden, we combine it with aspirin also, because we have put a stent.
How long do you give rivaroxaban?
Rivaroxaban, if there is a stent, it has to be given lifelong. And if it is a first episode of DVT, maybe 6 months to 1 year. So normally any DVT as per the guidelines up to 15 days we can use, because the thrombus after the 15 to 20 days becomes more organized and it is not amenable to lytic therapy. But for mechanical lysis we can do up to 1 month also, 1.5 months.
And dose of the actylates?
Sir, actylize we use generally 1 milligram per hour, sir. 1 milligram
Locally or?
to be infused inside the vein, inside the thrombus per hour. So we use up to sometimes 60 milligram, that means more than 2 days, sometimes 100 milligram, maybe 3 to 4 days sometimes.
With heparin or?
Along with heparin, because the lytic will lyse the clot. It will not prevent the further development of clot. So anticoagulation has to be given to prevent the development of clot.
Excellent lecture, Tarun bhai. For pulmonary embolism and large thrombus in the proximal pulmonary arteries, now penumbra is also available. So
Yes, sir.
what do you recommend? I mean, do you angiojet or penumbra, or which are any data?
Better than penumbra, there is another system which is available from Inari pharmaceutical, means Inari company. There's a clot reaver.
Yeah, so
So
those kind of device is
clot
better
reaver
or-
is better than angiojet, sir. Yes, sir. It is used in arterial thrombi also, because the other two catheters which were small, Omni and the second one, they are used in arterial system also.
So among the penumbra and this system, when you will choose a penumbra?
Sir, penumbra is a purely a aspiration catheter. You cannot give any lytic therapy through that. It is just a wide bore tube which helps you to suck the clot. So I do not have any personal experience of penumbra as of now. So I have used only angiojet or the simple guiding catheter to aspirate the clot,
And
if the patient is not affording
And
for
risk of
angiojet.
hemolysis in practice, how many cases you have seen?
Maybe, sir, in around 30 to 40% cases, hemolysis happens.
So
You have to be very careful in the hydration part. Otherwise, the patient can develop acute renal failure.
thank you, excellent. Yeah.
Sir, angiojet is costing around 2 lakh rupees. And the Actylize is costing around 50,000 rupees, 50 milligram. So the overall therapy for one case of DVT would be somewhere around 3 to 3.5 lakhs.
Okay, thank you very much, Dr. Tarun, and I request
Thank you.